Okay, so starting with the pharynx, first thing we need to talk about is the exam technique. We did talk about it in one of the previous lectures, but I'll go through this again. So you can do an X-ray of the soft tissue of the neck, lateral view. That is a good exam for some things in the pharynx, particularly when you're looking for soft tissue and for foreign bodies. After that, when you do the barium exam, it is done as a biphasic barium exam. What that means is that first you do a single contrast in the sense that in a rapid sequence filled phase like this. So the filled phase, that is this part, is actually the single contrast part of the exam. And then once the contrast has gone through in AP as well as in lateral views, we do what is called as the air-filled phase or air contrast phase. And that is by asking the patient to say E. What you tell the patient is to say E. It sounds funny, but what it does is it actually, in the air-filled phase, it distends the pharynx. It makes it bigger, and so you can get a better distension of the pharynx and you can see the areas very well. So then the next thing is when you are trying to do to actually study the motility of the pharynx, we look at the modified video swallow study, which is a study that is performed along with the speech therapist, and the patient is swallowing different types of barium. You can then see what exactly is going on and when there is aspiration or not. All right, so next we go on to the anatomy of the pharynx. And in this, basically, you have to know three things. One is the epiglottis, second is the valleculae, and the third is the piriform sinus. Now, epiglottis is seen as a structure that is curved upwards on the lateral view. So the space between the epiglottis and the base of the tongue is the vallecula, and that is seen on the AP view as two pockets right here, and they are seen better in the air-filled views than in the contrast-filled views. So vallecula is the space between the epiglottis and the base of the tongue. Piriform sinus is a pocket that is formed by the aryepiglottic folds, and that is seen over here on the AP view, and on the lateral view it is seen right over here. So these three things you have to know: the epiglottis, the valleculae, and the piriform sinuses. On CT also, it is the same thing. You can see the epiglottis here, and this is the base of the tongue. So between the base of the tongue and the epiglottis is the vallecular space or vallecula, and right here, this is the median glossoepiglottic fold, the fold between the epiglottis and the tongue, and these are the lateral glossoepiglottic folds, and between them are the valleculae. As we go down further, you start seeing the piriform sinuses on both sides of the pharynx, right behind the larynx. So these are formed by the aryepiglottic folds, which go from the epiglottis down to the arytenoid cartilage, which is right about here. The reason we need to know about these anatomical structures is because sometimes masses in the pharynx are not visible otherwise, and you have to make sure that you are seeing all the anatomic structures and they are not filled up by the mass. Once they get filled up by a cancer or a mass, you stop seeing them. There are four signs which are very important for pharynx. One is the swelling of the soft tissues. Second is the filling defects or masses. Third is presence of contrast protrusions. And the fourth is motility. And the diseases that we are looking for are the inflammations of the pharynx, the tumors of the pharynx, diverticula of the pharynx, extrinsic diseases, and motility disorders. So swelling of the soft tissues is important in telling us about inflammations of the pharynx. There are two areas of the pharynx that we must concentrate on when we are looking for the swelling of soft tissues. And by the way, this is seen best either on the plain views of the soft tissue of the neck or on a CT. So the two areas to concentrate are number one, epiglottis. And here is a normal soft tissue of the neck, and you can see that the epiglottis is nicely formed. It's curved upwards. It's right above the hyoid bone. And this is the airway going down. Pharynx is right here behind that. So when the epiglottis becomes swollen, where it starts looking like a thumb, and the aryepiglottic fold that you are seeing here, which is normally concave, becomes convex, that means that the patient has epiglottitis. It is caused by Haemophilus influenzae in children. Nowadays, it is becoming more common amongst adults because it can also be caused by streptococcus infections. So epiglottitis is the swelling of the epiglottis and also the convex appearance of the aryepiglottic fold, which is normally concave, as I'm showing here. The next area to look for swelling is the retropharyngeal space, and normally the retropharyngeal space front of the C1 and C2 vertebrae is thin, and then because of the presence of the pharynx, it becomes thicker. It can become quite thick when there is a retropharyngeal abscess. And not only does the thickness increase when there is a retropharyngeal abscess, sometimes people can also develop air fluid levels because of the presence of abscess. Also remember, whenever there is a retropharyngeal abscess, the spine is going to be concave. It is not going to have its normal convexity. Next, we go on to filling defects in the pharynx. They can be benign or malignant. The benign filling defects can be due to cricopharyngeus or presence of a web. So cricopharyngeus impression is a normal impression at the back of the esophagus, as we are seeing here. And it is located at the level of the pharyngoesophageal junction. Remember, cricopharyngeus is a transverse muscle that is right at the junction of the pharynx above and the esophagus below. So that junction is located at the level of C5-6 vertebrae. So C2, C3, C4, C5, 6. So C5 or C6. And the impression is usually transient. However, it can be abnormal and it can cause dysphagia, like in this patient, whereas it's also causing aspiration. And that can be an idiopathic occurrence, or it can also occur in neurologic diseases like after a stroke, or in muscular diseases, for example, in polymyositis or dermatomyositis. The next benign filling defect in the pharynx is along the anterior aspect of the pharynx, and that is called a web. It is less than 2 millimeters in diameter, and usually it is of no significance. However, sometimes it can be very prominent and it can cause obstruction. Now, when to say whether the web is causing obstruction or not? One is that the patient will be symptomatic. Second is you can give them a tablet. And the third thing is you can also look for the dilatation of the pharynx above the level of the web. If it is dilated, then that means that this web is significant. So the webs can be also idiopathic, but another condition that causes a web is called Plummer-Vinson syndrome, where there is iron deficiency anemia and dysphagia due to the presence of a web. These webs can also, in these patients with Plummer-Vinson syndrome, they can become carcinomatous, and that is called a post-cricoid carcinoma, because these webs occur at the level of the cricoid cartilage, right behind the cricoid cartilage. Now, if you look at the anterior aspect of the pharynx in these images, there are these tiny, small filling defects along the anterior aspect. And these are due to pharyngeal venous plexus. This is a normal thing. You don't have to worry about it, but when you see it, you shouldn't call it abnormal. So the three benign filling defects of the pharynx: cricopharyngeus impression, webs, and pharyngeal venous plexus. Now, filling defects can also be from extrinsic impressions, like in this case. Here what we are seeing is the pharynx contrast is coming down, but the pharynx is being pushed to the right by a smooth impression here. Now, this impression is very different from a cricopharyngeus impression or a web. And by the way, people have called cricopharyngeus as cancer when we show them cases. So make sure that you don't start calling it a cancer, a cricopharyngeus impression. But this one is an extrinsic impression. How do we know? Well, it's a smooth impression. The sulcus angle is obtuse, and it is just pushing the pharynx to one side. And in this case, it is a impression from an enlarged thyroid gland. Now, malignant filling defects, so they can be very prominent, like in this case, there is a large mass. Where do the cancers most likely arise in the pharynx? They arise in the valleculae, which is here. One vallecula is here, second is here, and here you are seeing a large mass. And this is extending down into the hypopharynx, and also involving the piriform sinus on the right side. So on the left side, you are seeing the valleculae and the piriform sinus, but on the right side, you're not seeing them, but you're seeing a very nice mass. This is, of course, a cancer. Now, sometimes you cannot really see the mass, like in this case, but when you notice that there is a vallecula filling up here, but there is no vallecula on this side, then you start seeing the outline of a mass. So that is why it is important to recognize and look for these three structures: the epiglottis, the valleculae, and the piriform sinus. Same patient, the CT scan shows vallecula is nicely filled with air on the left side, but on the right side, it is filled with a mass. Now, contrast protrusions or depressed lesions, as we have seen in the past. So they can be due to aspiration, diverticula, or perforation. So let's go on to aspiration. Aspiration is not uncommon, particularly if you have an older age group. And it can and it is defined as, or you recognize it when there is contrast flowing into the larynx. You can see the glottis here, the vocal cords, and then it is going down into the trachea. A lot of times, presence of an obstruction can cause aspiration, but also presence of neurologic diseases like stroke can also cause aspiration. So in this case, there is a pretty significant aspiration. Now, in this case, the aspiration is even more because the contrast has gone down into the trachea and into the bronchus. So this patient had obstruction here, and here the contrast is going down into the trachea due to a pretty significant aspiration. On the lateral view, aspirations are easy to pick up because you can see contrast here. But you should also be able to pick it up on the AP view, where you will find that there is the contrast is going down in the midline below the level of the piriform sinuses. See, what happens is, if I may show you a normal piriform sinus, here is the piriform sinus. This is the inferior pharyngeal constrictor. You can see the muscle fibers over here. That closes it. But when there is contrast going anterior to it, that is going to be going down in the midline. Whereas in the normal pharynx, you do not see any contrast in the midline. Same valleculae here, epiglottis over here, and piriform sinuses, but there is contrast. And here you can see the contrast filling up the glottis, which you can see here. Here it is filled with air, but in this case it is filled up with contrast. So there is aspiration on AP view. Now, sometimes aspiration is only transient, in which case it is called penetration. What that means is that contrast goes out between the below the level of the epiglottis into the opening of the larynx, and then it comes back in. It does not go down into the actual airway. So this is called penetration. What that means is that such patients may actually aspirate at some point, but they are not aspirating right now, but they are on the danger of an aspiration. Now, whenever you see an aspiration, what are the questions that you must ask and answer? One is, you must find out what is the severity of aspiration, because anybody who is aspirating more than 10% of the bolus, they cannot be fed because they will develop pneumonia. Second thing is the patient aware of aspiration? Usually when the patient aspirates, they will start coughing. But if they don't cough and you can see the aspiration, the baric contrast going down into the trachea, then that means they are not aware. And you should ask them, do you know that it is going the wrong way? And a lot of times they'll say, no, I don't know if it is going the wrong way. So they need to be, because if they are not aware of aspiration, that means that they cannot be fed and they have to be, some other way of nutrition has to be maintained. Third is, can the patient clear the airway or not? Let's say the contrast has gone down into the trachea. You ask them to cough and see if it will come out and if the trachea will get cleared. Because if it is not, then again, there is a high risk of aspiration pneumonia. And the last thing that you want to know is which phase of the swallowing does it occur. Does it occur early in the swallowing, middle phase of the swallowing, or late phase of swallowing? Because the cause of aspiration, it decides when the aspiration occurs. So, and I'm not going to go into detail of that, but you should know that the cause of aspiration can be determined to some extent by deciding which phase of the swallowing it occurs in. Diverticula arising from the pharynx. Whenever you see a protrusion that looks like a diverticulum, you have to ask yourself, is it posterior or lateral in position? Is it high or low in location? What is its relation to the cricopharyngeus? And what is the size of this diverticulum? Because there are a number of types of diverticula that can be seen in the pharynx. There are the lateral pharyngeal diverticula, as I'm showing you here. It is high up in the pharynx. This is the lower border of the mandible. This is the back of the tongue, and this is the lateral pharyngeal diverticulum. The vallecula is here, epiglottis is here. Now, these things are called the retromolar recesses. This is the space behind the molar teeth in the mouth. So these are not diverticula. Do not mistake them for diverticula. But these here are called lateral pharyngeal diverticula. There is another image, a better image from the literature, but basically they are of no real clinical significance unless they are collecting food. Now, diverticula that is arising from, or a diverticulum that is arising from the lateral aspect again, but it is arising low down, close to the pharyngoesophageal junction, is called a Killian-Jamieson diverticulum. What is the relationship of Killian-Jamieson diverticulum to the cricopharyngeus muscle? It arises below the level of the cricopharyngeus muscle, actually from the upper esophagus. The Killian-Jamieson diverticulum does not arise from the Killian dehiscens, which actually is along the posterior aspect, and that is the origin of the Zenker's diverticulum. So don't be confused. Killian was a surgeon who described the Killian-Jamieson diverticulum as well as the Killian's dehiscens. Therefore, the name is kind of confusing, but Killian-Jamieson diverticulum does not arise from the Killian's dehiscens. This is something, anatomy, that people are quite fond of asking. Now, if the diverticulum is occurring posteriorly see, we were looking at the diverticula that were lateral, but this one is posterior, and it is in the midline, posterior midline, then that is a Zenker's diverticulum. And what is the relationship of Zenker's diverticulum to the cricopharyngeus muscle? If you can see the cricopharyngeal impression, the Zenker's diverticulum will always be above that level because it arises from Killian's dehiscence. Going on to the esophagus now. Again, exam technique. The upright double contrast images are obtained in the LPO position, with the patient standing with their back towards the table and turned towards the left. Then the motility of the esophagus is observed on the prone RAO views, with the patient lying prone with their face down and their left side a little bit up so that their right side is towards the table. And reflux is checked with water siphon test in the RPO position, with the patient lying supine on their back. You ask them to start turning towards their right side as they drink water. And as they drink water, if there is reflux, the barium will come up. Anatomy of the esophagus, of course, there are these areas of normal narrowing. This is the subclavian artery in front. That is the arch of the aorta, left mainstem bronchus, and the left atrium, as we have seen it in the previous lecture. Those areas you must know. But we also you should get used to the normal mucosal pattern of the esophagus. In the distended state, in an air contrast study, the mucosal folds are not visible. It is a smooth mucosal pattern. But as we go further on and it becomes collapsed, that is called a mucosal relief image. And in these you are seeing the mucosal folds which are longitudinal in the esophagus. Remember, the folds in the esophagus and the stomach are longitudinal. Folds in the small bowel and large bowel are transverse. So this is, again, if you cannot get a good mucosal coating, this is a good view to look for the mucosa. These folds are always less than 4 in number. If they are more than 4, that means the stomach has come up. That is how we differentiate between the esophageal folds and the gastric rugae in a patient who has a hiatus hernia. So mucosal folds. Now, motility of the esophagus, it consists of primary peristalsis and secondary peristalsis. Primary peristalsis is an inverted V-shaped area at the top of the bolus. As it goes down, as the bolus goes down, this V also moves downward. That is called the stripping wave or the primary peristalsis. It should completely clear the esophagus of any barium other than what is coated on the folds. Now, secondary peristalsis is when a portion of the bolus, food bolus, is left in the esophagus will start contracting from that area and it will form the secondary peristalsis. So these are normal. The third is the tertiary contractions, which are not normal. They are non-propulsive contractions, meaning they do not cause the bolus to move. All it is the esophagus going into tremors, and you start seeing tiny tertiary contractions, some of which we'll show you later on. Signs of esophageal disease. We look for the caliber. We look at the wall and fold pattern, filling defects and masses, contrast protrusions, and motility. And the diseases that we are looking for are luminal diseases like foreign bodies, epithelial diseases like ulcers and masses and cancer, and then submucosal diseases. It should read submucosal disease like tumors arising from the submucosa. Extrinsic diseases, involvement of the esophagus in in the diseases of the mediastinum and motility disorders. So caliber, it can be dilated or it can be narrowed, right? We know that from our previous lecture. So esophageal dilatation is interesting because esophagus is so muscular, it does not dilate easily. For esophagus to dilate, there has to be either some abnormality of the wall or the esophagus has to be obstructed for a long time. Long-standing obstruction occurs in patients with achalasia, and abnormality of the wall occurs in patients with scleroderma. Apart from these two conditions, the esophagus does not dilate significantly with just obstruction. Acute obstruction is not enough to cause dilatation of the esophagus. So, talking about achalasia, so basic hallmark is that the esophagus is significantly dilated and that the lower end there is a narrowing at the lower esophageal sphincter so that it forms a bird beak appearance. If you can look at this, this is the head of the bird upside down, that is the chest of the bird, that is the beak, so bird beak appearance. And what happens is when you give a contrast, the barium keeps on filling up until it reaches a certain level where it overcomes the resistance of the this narrowed lower esophageal sphincter and it becomes dilated. And it begins to empty into the stomach. The gastric air bubble is empty. Now you can see this same thing on a chest x-ray also, and you should be able to recognize. What you will see is a double heart border which does not finish at the level of the atrium. It goes all the way up because it is the dilated esophagus. What else causes a double heart border? A left atrial dilatation, but that will end over here, whereas a dilated esophagus will give rise to a double heart border on chest x-ray. So the two main signs, dilated esophagus and bird beak appearance of the gastroesophageal junction, these are the two signs of achalasia. Now, another thing that needs to be separated from achalasia, achalasia normally is a primary achalasia. What the pathology is that the ganglion layer in the esophagus is absent, so there is a spasm, kind of a increased resistance of the lower esophageal sphincter. Now this can also occur when it is destroyed by trypanosoma parasite, which occurs in Chagas disease, but it can also have something else, can have a very similar appearance, and that is when there is infiltration of the lower end of the esophagus by a cancer. So that is called a secondary achalasia, and this secondary achalasia needs to be differentiated from the primary achalasia. So there are three things that will help you do that. One is that the esophagus may not be that much dilated as in the primary achalasia. Second thing is that the history is usually less than 6 months in secondary achalasia. Why? Because if the patient has cancer, they are not going to live longer than 6 months. Whereas in achalasia, it has been going on for many years. Third thing is, when you look at it carefully, you may be able to see nodularity of the bird beak appearance of the narrowed lower esophageal sphincter. So those are some of the things that you need to be able to differentiate between primary achalasia and secondary achalasia due to cancer. Another almost a variant of achalasia is called vigorous achalasia, also called a corkscrew esophagus, where you start having this corkscrew appearance of the esophagus because of these very strong tertiary contractions, which in some cases can obliterate the lumen, and all you may see is tiny segment or small segments of barium. So again, it is a neuromuscular disorder. Scleroderma also causes dilatation, which looks very similar to achalasia. But the difference is that in scleroderma, the lower end of the esophagus, the lower esophageal sphincter, is wide, or it is also called patulous, because there is no resistance there. So this is on a fluoroscopic study. This is on CT. Again, you see a very big, wide, dilated esophagus. And as we come down, there is no tone in the lower esophageal sphincter. This is very typical of scleroderma. Whereas in achalasia, you will find dilated esophagus, but narrow gastroesophageal junction. Again, these are some of the typical examples, and they are often asked in different types of exams, and also they come in handy when you are dealing with a patient. So narrowing of the stricture, narrowing of the esophagus, and this is going to be a little out of, I'm going to bring them all together. Okay. So the narrowing of the esophagus can be due to a stricture, or it can be due to rings and webs. Stricture can be benign because of reflux, chemical injury, pills, radiation, or it can be malignant, and you need to be able to differentiate between these two, as we have seen in the past, but we'll go over it again. So benign narrowing due to reflux stricture, typically it is at the lower end of the esophagus. It is smooth, and it has smooth tapering margins. There is no destruction of the folds. There is no ulceration. There may be some organized ulceration, but in this case, we don't see any ulceration. So this is typical of a reflux stricture. We are also seeing a hiatus hernia. Like I said, there are more than 4 folds, 1, 2, 3, 4, 5. So this is not a part of the esophagus. This is a part of the stomach that has come up. Apart from strictures, the esophagus can, the reflux can also cause reflux esophagitis, and one of the typical appearances of that is a presence of a small polyp or thickened fold, which is called a sentinel fold. Here and also here. Here you can also see some ulceration. When you see that, that means that this is typical of reflux esophagitis. The reason you should be able to recognize that is, if you see that on a barium study, then that means you need to look for reflux more carefully than usual. The other thing that reflux esophagitis can do is ulceration, which can be very subtle. It is these tiny sharp ulcers, which again occur in the distal esophagus. So that is typical reflux disease. However, reflux strictures can occur elsewhere also. They can occur in the middle of the esophagus, they can occur at the upper part of the esophagus. In this case, there is a stricture in the middle of the esophagus, and whenever you see a reflux stricture or a stricture which is away from the distal end and there is reflux, then you have to consider Barrett's esophagus or Barrett's stricture. The Barrett's stricture is important to recognize because it is a precancerous condition. And by the way, it occurs more commonly in patients who have scleroderma. About 30% of scleroderma patients will develop a Barrett's esophagus. Barrett's esophagus also may show some nodularity in the area, like in this case, as a nodular plaque. And rarely, it shows this tiny reticular pattern, which is very similar to the area gastricae of the stomach. Now, these two patterns are rare, but this is not seen uncommonly. This is seen quite often. But whenever you see a patient with reflux disease and there is a stricture away from the distal end, consider Barrett's stricture. Other benign narrowings can be are due to chemical stricture, which are typically long, and they can be multiple. They can involve the stomach as well as the esophagus. Now, reflux can also cause a long stricture like this. And again, see, it is benign. There's tapering ends and long stricture, no ulceration at all in this case. So, whenever you come across a long stricture, then it is a question of history. Is there any history of ingestion of chemical? Because if a patient has such stricture, there has to be, they will know whether they tried to commit suicide by drinking chemical like sodium hydroxide or by drinking acid. And if that, then that means that it is a chemical stricture. If not, then you have to consider a reflux stricture, which can also be long. Pill-induced strictures are again in the portion of the esophagus where there are normal areas of narrowing. So at the upper esophageal sphincter, at the point where the aorta crosses it, or at the point where the left mainstem bronchus crosses it, the pills will get stuck there and cause a chemical esophagitis. Which are the types of pill that can do that? Antibiotics can do that, and potassium chloride pills, particularly on patients who are taking digoxin, can do that. So if there is a stricture at the points of normal narrowing, you must raise the possibility of pill-induced stricture. But also remember, if there is no history of pills, then the differential diagnosis is Barrett esophagus, because it is a stricture not occurring at the lower end of the esophagus. So next is benign narrowing due to rings. So, okay, this we need to go down. Benign narrowing due to rings. So normally you will find that the lower end of the esophagus is quite smooth. Sometimes you will actually start seeing the various parts of the anatomy of the lower esophageal sphincter, because lower esophageal sphincter is not just a linear thing. It extends over a 2 to 4 centimeter long segment, which is called the vestibule of the esophagus. This is seen when there is a small hiatus hernia, like in this case, and there are then you will be able to see 3 rings. So the top one is the A ring, which is the actual muscular portion of the lower esophageal sphincter. It will change its appearance with contraction because it is muscle contraction. As you go further down, you will find the area of B ring, which is the junction, squamocolumnar junction, which is the junction of the squamous mucosa with the columnar epithelium. Squamous epithelium in the esophagus, columnar epithelium in the stomach. So this is the B ring. And then the C ring is the narrowing caused in that stomach by the diaphragmatic hiatus, because there is a hiatus hernia. These are seen only when there is a small hiatus hernia. Now, sometimes the B ring will be so prominent, these mucosal webs, that it will form a web. And in that case, then the patient often comes with dysphagia, and that is called as a Schatzki ring. Now the question arises, like in this case, this is the A ring, this is the vestibule, and then the B ring, and the C ring is here. The question arises, is the patient's dysphagia being caused by this narrowing, or is it just a narrowing like in this case? So to differentiate between those, you have to give the pill. And in this patient, the pill got stuck at the level of the B ring, and we proved that by giving barium, a little more barium, and after the pill, and the pill just didn't go down. That means that the lumen of this is less than 13 millimeters, and therefore this ring is symptomatic. And these are called, symptomatic B rings are called Schatzki ring. Malignant strictures due to cancer, they are again typical. They can occur anywhere: upper esophagus, middle esophagus, lower esophagus. The important part is that there is shouldering. That is the most reliable sign. It is not a smooth tapering ends. There is shouldering or abrupt end. The esophagus is coming, it is fine, and then suddenly, bam, you get the stricture starting. Second thing is that the stricture is irregular and it is very haphazard. Here is another one: shouldering and mucosal destruction. There is no organized ulceration. There are ulcerations here. So that is again a malignant stricture. Third is again the looks like achalasia, but you start seeing nodularity. That is a pseudoachalasia type malignant stricture. Filling defects, going on to the filling defects because we are at cancer, they can be luminal, within the lumen, they can be from the wall, or they can be extrinsic. If they are within the lumen, then it's usually food or foreign body. If they're arising from the wall, it's epithelial, which can be cancer, or subepithelial like gist and varices. If they're extrinsic, then it can be due to vessels, lymph nodes, or duplication cysts. So luminal filling defects, here is a patient who had swallowed a metallic thing, and if you look at it on the PA view, it is lying en face, but on the lateral view you can see it in profile, right? That means that it is in the esophagus, because the esophagus, if you think about it, is a tube that is longer, that is wider than it is long, whereas trachea is AP diameter is more than the transverse diameter. And whenever you see a coin, see a metallic structure like this, don't always think that it's a coin. Look for this area, this peripheral indentation, which tells you that this is a battery. And once you know that it is a battery, now it is a emergency, because the battery can cause current inside, and because of the presence of acid, and it can lead to a burn in the esophagus and therefore perforation, and you don't want that happening. So therefore presence of a battery is an emergency for removal. Food or surgical or soft things can appear like tumors almost in the esophagus. Now the one thing that I want you to remember about food impaction is that in any patient who has food impaction, you have to, after the impaction has been relieved, after the food has been removed, you have to do a barium study to make sure that there is no stricture that caused the food impaction, right? Food is not going to just collect somewhere just like that. There usually is something that is causing stopping the food from going down. So therefore, you must look for a stricture in a patient who has had food impaction. Then here is another foreign body that you will find. This is in the pharynx, a chicken bone. You may or may not be able to see it. Similarly, fish bone, you may or may not be able to see it depending on whether the fish is cartilaginous or it contains a bone. But on CT, often you will be able to see the bone. Filling defects can be caused by cancer. So these are arising from the wall. So this patient has a long sentinel fold, and there is a polypoid filling defect here. This is also, there is retraction of the underlying wall of the esophagus, which shows that it has invaded into the wall. So this is a polypoid type of cancer. This is a type of cancer which is called the fungating cancer, which means that it is almost cauliflower-like. And again, you're seeing multiple lobules, and the sulcus angle is acute, and it is and the mucosa is destroyed. Now this is an ulcerating type of cancer, and what you are seeing here is the presence of a mass, and then the barium is filling that space within the mass itself. So there is a large ulcer within the cancer, and this ulcer is not extending beyond the line of the esophagus, so there is no penetration. That means that this is a malignant ulcer, and this is actually forming a collar. Same thing is seen in the stomach. Subepithelial filling defects can be caused by varices. You will very rarely see them nowadays. They are mostly seen on CT, but they appear like multiple nodules. And actually, if you follow them, you can actually connect them into these tortuous vessels. These varices can sometimes, similar appearance can be given by a type of cancer which is called the varicoid cancer, meaning that it looks like varices, except that varices in various parts of the swallowing process will empty and fill up, and therefore will show a variable appearance, whereas a varicoid cancer will not. Once you do a CT, of course, there is no question that these are varices, and this is not a cancer. Varices that extend above the level of the azygous vein are called uphill varices, and they are caused by SVC obstruction, depending on whether it is below or above the level of the azygous vein. The varices that are below the level of the azygous vein, they are called the downhill varices. They are caused by portal hypertension. Now, another subepithelial filling defect can be caused by leiomyoma. It's a small, cute little tumor filling defect, very smooth, no mucosal destruction, and the sulcus angle is either obtuse or it's almost right angles. The center of the thing is kind of here if you drew a circle. So again, a rare tumor, subepithelial tumor of the esophagus, but it can occur. More commonly, what you will find is the more common subepithelial tumor of the esophagus is a gist, and that occurs as a large bulky mass. But again, even here you can see that it is smooth. It is causing nodules which have the appearance of subepithelial nodules. And on CT, again, it looks like a bulky tumor. That is the lumen of the esophagus, and that entire thing is the tumor. Extrinsic impressions can also appear as filling defects, like in this case where the esophagus is coming down and suddenly it is being displaced, and there's almost like a filling defect. But if you look at it more carefully, the margins are obtuse, the folds are stretched. Actually, if you look at it, if you can see the folds, they are being displaced along with the filling defect. That means that it's an extrinsic filling defect, and what lies in this area? The abdominal aorta, the descending thoracic aorta. And there you also have some calcification. So typical impression of descending thoracic aorta. Extrinsic filling defects can also be caused by malignant lymphadenopathy. Again, the same thing. You know that it is coming from outside. Here it may look a little submucosal, but otherwise it's coming from outside, and there is stretching of the folds. And when you look at it, there is the esophagus. This is the actual lymphadenopathy. It is pushing it away. It's not really invading the wall of the esophagus if you look at it. Now, other extrinsic or rather congenital vascular defects you need to know about, because they can be shown and you can be asked, and you'll also see them. Congenital vascular defects usually appear as band-like structures. So this is, so what do you need to do when you see a band-like filling defect? You need to find out, is it posterior or anterior? Posterior filling defects are caused by anomalous subclavian artery, like in this case, left-sided aortic arch, the right subclavian artery, which should have arisen here, is arising here and passing behind the esophagus and producing this defect. Or it can be caused by double aortic arch, because in a double aortic arch, the anterior arch is in front of the trachea and it does not cause a filling defect on esophagus. The posterior arch is on the back of the esophagus or behind the esophagus, so it causes a posterior filling defect. Anomalous left pulmonary artery is something that will produce an anterior defect. It's always located between the trachea and the esophagus. Therefore, the defect will be anterior. So just a little thing on congenital vascular defects. Duplication cysts are another thing that can cause a filling defect. So like in this case where you're seeing a very smooth, almost submucosal filling defect, it could be a leiomyoma or GIST also. When we did a CT, we find that this is actually a cystic area and therefore it is a duplication cyst. On MR also, you can see this as a cystic abnormality which doesn't show enhancement. Now, contrast protrusions can be caused by ulcers, diverticula, fistulae, or perforation. Contrast protrusions can be due to ulcers can be due to peptic disease like reflux disease, candida, herpes simplex virus, cytomegalovirus, HIV, and malignant. Again, these are some things that are very favorite of the examiners all the world over, and also you need to know them clinically also. Diverticula can be due to traction or pulsion type diverticula, or there can be pseudodiverticula. Fistulae can be through the skin or trachea. Diverticula can be pseudodiverticula, and perforation can be mucosal, mural, or transmural. So let's go over them quickly. The ulcers, like I told you, they can be caused by multiple different diseases. So here is one of the ulcers. You can see them here, tiny sharp ulcers located just above the gastroesophageal junction in the distal esophagus. Those are typical of peptic ulcers. Now, if you start seeing linear ulcerations and transverse ulcerations with nodules, that is typical of Candida. Very superficial ulcers, small, are typical of herpes simplex V, and large ulcers but superficial like here, 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 those are typical of CMV, which occurs in patients with AIDS. But in those patients, HIV esophagitis can also give rise to similar ulcers. Therefore, very important, because the CMV ulcers are treatable, HIV ulcers are not, you need to do a biopsy to make sure that you diagnose CMV by an endoscopic biopsy, because the treatment for CMV is quite toxic, and therefore you need to be able to do the biopsy and make the correct diagnosis. Diverticula can be of the pulsion type, like here, smooth diverticulum containing a lot of food debris. It is located at the lower end of the esophagus, so that is a pulsion diverticulum. Or the diverticula can be of the traction type, which do not have a round appearance, but they have a tent-like or conical appearance, as if something is pulling them forward. And if you look at the CT scan in this patient, you find that this is the esophagus, those are the two diverticula, and there is a calcified lymph node, which is actually responsible for formation of these diverticula. They contain all layers of the wall, and therefore they do not usually contain residual contrast or food, whereas pulsion diverticula do. Next is the pseudodiverticula or intramural pseudodiverticulosis, which appears as tiny outpouchings which may or may not communicate with the wall. And actually these are not diverticula, they're called pseudodiverticula because they have collection of barium in the distended submucous glands of the esophagus. So that is intramural pseudodiverticulosis. This one is diffuse, but it can also be localized, particularly in association with a peptic stricture. This patient has a Barrett's esophagus and there's a stricture there, but these are intramural pseudodiverticula. So it can be diffuse or it can be localized. Fistulae, there can be fistula with the skin, like in this case, with a patient had laryngectomy, and you can see an esophagocutaneous fistula coming through the tracheostomy site from the esophagus, around the tracheostomy, I'm sorry, and out into the skin. Or fistulae can be formed with the trachea, like in this case where there is a involvement of the esophagus, there is an esophageal cancer which is invading into the trachea, and there is a breakdown, and you can see contrast entering the trachea through a fistula. Perforation of the esophagus can be due to mucosal tears, which is also called the Mallory-Weiss syndrome, and usually it is not seen, but sometimes on CT, especially if a patient has chest pain, you may be able to see small amount of air in the thickened esophageal wall. And if you do a barium study, you'll find a linear ulcer that is typical of a mucosal tear or Mallory-Weiss syndrome. These patients usually present with hematemesis and chest pain. But the second type of perforation is a mural dissection, which occurs when a false passage is formed by endoscopy, particularly if the patient has a stricture. This patient had bronchogenic carcinoma, was treated with radiation therapy, developed a stricture. The gastroenterologist was doing endoscopy and caused a perforation. And that perforation can be seen here. You can see the contrast in the area of perforation, and there is a hematoma around the esophagus. So typical of mural dissection. This is a patient who had vomiting and developed an emetogenic transmural perforation, also called Boerhaave syndrome. And in this you can see that there is really, this is the esophagus, contrast is all over in the mediastinum, there is air in the mediastinum, and there are bilateral pleural effusions, larger on the left side. This kind of perforation usually occurs along the anterolateral, left anterior aspect of the esophagus, and this is typical of Boerhaave syndrome. The last part that I'm going to do very quickly is T-staging of the cancer by esophageal cancer by CT. And we'll go through this. This is not the slide. We'll go to the next slide. Yes. So T1 and T2 cancers are within the esophageal wall. We cannot diagnose it on imaging other than transesophageal ultrasound, which doesn't fall within our preview. That goes to the gastroenterologist or the surgeons. T3 is involvement of periesophageal fat, but not any neighboring structures, and T4 is neighboring structure invasion. This is typical of calcification or T classification of most of the tumors. T3 is tumor around the organ in the fat, but no other neighboring structures. T4 is neighboring structure involvement. Now, in the esophagus, how do we know whether there is a neighboring structure involvement or not? So if there is an intact fat plane, like in this patient with an esophageal tumor, there's an intact fat plane here. So that means that the right atrium here is not involved, right? Now, if there is an interface irregularity, that means invasion. So there is interface of the tumor with the right mediastinal pleura. There is irregularity, so there is invasion. And in this case here, there is no fat plane, but there is no irregularity either. So what do we do then? So in the esophagus, there are a few rules that you need to know. One is that if there is if there is a concave interface between the tumor and the trachea or bronchus or the left atrium, there is involvement of that. So here is the tumor. There is involvement, there is concavity of the interface with the left mainstem bronchus. So that means that there is invasion of the bronchus. Similarly, concavity here, that means invasion of the pulmonary. For the aorta, if more than 1/4 of the aortic circumference is involved, that means that there is invasion. Here there is less than 1/4, but here almost half of the circumference is abutted, so that means that there is invasion. And third is, if the tumor is filling the fat plane between the esophagus here, the aorta, and the vertebral body. Esophagus, aorta, and vertebral body, if it is filling it, that means that the aorta is invaded. In this case here, there is destruction of the vertebral body also, so that is it. And the one last thing that I want you to remember is, how do we divide the esophagus into the upper, middle, and lower for the purpose of cancer? Upper esophagus is above the level of the lower margin of the azygous vein. Okay. The middle esophagus is from the lower margin of the azygous vein to the lower margin of the pulmonary vein. And below that is the lower esophagus. And with that, we come to the end